the best visual acuity happens with the RGB contact lens. Then we start discussing with the patient, which I think it's very important, discussing the patient, what is your vision requirement so that I can offer him the best thing for him. So if he cannot use the glasses or the contact lens, I might think of the intracorneal ring segments to reshape his cornea, and then we can do him refraction, glasses refraction later on so that he can see better. And if the patient doesn't like this idea, I think with RGB, he cannot use the intracorneal rings. I'll go direct for the keratoplasty.
Carry on.
So, again, the management options that we have for keratoconus are different. And as I mentioned, we all know the definition of keratoconus, which is an ectatic corneal dystrophy, causes high degrees of irregular myopic astigmatism, usually starts in the early ages, between 10 to 15 years, starts to increase up to 20, 30, or 40 years. Most of the cases are bilateral, although there are unilateral cases, very rare. The grading of the keratoconus is different according to keratometric grading and the corneal thickness, the presence of scars or not, and other issues. And the more common is the Cromish classification, which classified keratoconus into 4 stages. And again, we have different options according to the progression of the disease, the visual vision of the patients, and accordingly, if the patient is usually early and progressive, I'll do him cross-linking, and I'll give him the refraction or glasses or RGB contact lens. And then if he progressed more, even with the cross-linking, then I can think of having this keratoplasty. So it's very similar to what I said before, that I'm looking for the vision of the patient first and then try to control his weak cornea. So what are the managements that we can do for him for stabilizing his cornea? This is the corneal collagen cross-linking with riboflavin. And this usually indicated in the early cases or the progressive cases, in all cases of keratoconus and ectatic corneal dystrophy and even the post-LASIK ectasia. So a part of the other indications of the cross-linking. It's usually done once, although it can be repeated if you find that the case was not progressed, and taking into consideration that the corneal thickness enables you to this cross-linking. And it is all behind the cross-linking between the lamellae of the cornea, where it is enhanced, increased, so that the cornea becomes stiffer and doesn't steepen or progress more. So usually if the corneal thickness is below 400 or the key readings are very high, more than 60 diopters with a central scarring, we cannot do this. And if the case is stable or at the late ages, usually there is no benefit of doing this cross-linking. I'm usually following the classic cross-linking, where we have to stay for 1 hour in a patient, putting the drops, staying for 30 minutes, administering the drops over the cornea, and then subjecting him to the ultraviolet irradiation for another 30 minutes with lubricants and, again, riboflavin during this irradiation. So what's the advantages of this cross-linking? It's a very easy and cheap method to treat this cornea, and it is effective. It causes corneal really stabilization. About more than 80 to 90% of the cases are stable with 1 session of cross-linking, and it's safe. It doesn't have that much complications, except of simple scarring sometimes, and it might be improved with medication. And with follow-up, long-term follow-up, you can find that the cornea might be a little bit flattened than the preoperatively before doing the cross-linking. What are the other managements? As I said, we have to think about the other side, the vision of the patient. If the patient is diagnosed early with a good vision, with the normal refraction, we can give him glasses and or soft contact lenses. And as I said, RGB contact lens is very important, but it gives a very high success rate. The indication usually in the early cases, and usually the near vision is improved near to 2020. And of course, more cases are discovered nowadays because more patients are coming for seeking refractive surgery, and you see changes in the cornea. Either you categorize it as an early keratoconus, form frost keratoconus. So this is a very important issue to be in mind, that you can give the patients nowadays glasses for use for vision. Of course, the spectacles has its disadvantages as well as the contact lenses. So if we move to the surgical parts of the treating options of keratoconus, we can find that the intracorneal rings still exist in a way in between doing the keratoplasty and the RGB contact lens. And in the past, the intracorneal rings was tried to be used in cases of myopia, but this was obsolete, and they started just to be working on cases of keratoconus. The action or the mechanism of action by arc shortening and flattening of the corneal lamellae, so it changes a little bit the curvature of the cornea, remodify the shape of the cornea so that we are able to do glasses for the patients thereafter, or even toric soft contact lenses. Of course, the thicker the segment, the more flattening which will happen. The more central the rings, the more effect will happen to the cornea. So accordingly, we have different types of intracorneal ring segments, like the Intacs and the Ferrara, working on the 6 or 7 millimeters with the Intacs, and working on the 5 millimeter with the Ferrara rings. And each one of them has its different designs for acting on the cornea. Both shares that they have different thickness so that they can treat different grades of keratoconus. So when can I use these intracorneal ring segments? If the patient is RGB contact lens intolerant, or cannot see with the glasses well, and when the best corrected vision can be up to 2100 or something like this. And the K readings should be between 55 and 60 and have, again, a good pachymeter. So the femtosecond was introduced in this area, and of course the creation of the tunnel was much better with the femtosecond laser, because we have different benefits of this by making the channels more tight, and the effect of the rings might be better with a tight channel. Again, the centration of the tunnels will be helping in making the cornea flattened more. The well-implanted intracorneal segment should be in the deep stroma, 70 to 80% of the stroma, and it should be in symmetrical position so that it gives a good effect, and the segments should be far from the incision so that it will not be extruded outside. It's an easy procedure, and many of the patients, after putting the intracorneal ring segments, can be fitted with the soft contact lenses and glasses as well. But again, it has a slow recovery, so you can expect that the patient will feel the improvement after the putting the rings 3 to 6 months, and sometimes it causes halos around light according to the type of rings that you are using, and according, of course, to the pupil of the patient in the mesopic pupil diameter. But it doesn't eliminate the whole refractive error, and this is a very important issue before doing the rings, to inform the patient that this is not a refractive surgery, and we'll try to modify the shape of your cornea so we can give you glasses later on. This is very important. Of course, different types other than these are present in the market nowadays. The issue now is using the cross-linking with the intracorneal ring segment, which is done first, the cross-linking on the rings or both together, the same issue, a long of debate about this issue all over the world. The second option will be keratoplasty, either penetrating keratoplasty or better to do the deep lamellar keratoplasty with the air bubble technique or the hydrodissection or air gel. So we get rid of the diseased cornea and then put normal tissue or normal corneal tissue, and this can be done either with the traditional technique or again the femtosecond laser. So it's a radical solution, anatomical at the same time, but the function recovery of the vision of the patients usually takes up to 1 year, sometimes more, to give him a good vision after the operation. And of course, we are using medication for a long time to control the rejection of the grafts. And it needs long-term follow-up. The other options which is available sometimes are phakic IOLs, where they can be used after in cases of stable keratoconus or cross-linked stable keratoconus after the intracorneal ring segments, what we can call bioptics, modifying the shape and then putting the residual refractive error, correcting it with the toric phakic IOLs, or after even keratoplasty. Again, which one to be done first, cross-linking or phakic IOL? If you find a patient with a stable refraction for a long time and stable cornea for a long time, and you have a proof of this, I think we can implant him phakic IOL if the vision is improved for a good level, and follow up him. And if you find that the cornea is progressing, you can do them cross-linking thereafter. So just at the end, decision of the type or solution for these cases, you have to discuss it thoroughly with the patients. You have to take the opinion of the patient. You have to let him know what he's going to have exactly, and be sure of the corneal keratoconus stability, both by refraction and topography. And remember always that the keratoconic patients have two problems, vision and weak cornea, and use all available options to get the best visual outcome for the patients, and follow up the patient every 6 months, whatever you are doing to the patient. Again, this is the diagram I'm following, and I want to thank you for your kind attention.
Okay, may I now invite ever willing, untiring Jorge Alio. The topic is grading and treating keratoconus with ring segments.
Thank you, sir. Honored to be in a session presided by you, one of the icons in cornea surgery, so thank you. And the answer to your question, to your patient, will be offered to you by my presentation. I believe in the tutorial didactic model, so I will offer to you the answer, and you will see by yourself what I am advising in your case. The topic is grading and treating keratoconus with intracorneal ring segments, and I want to show to you a new perspective on this topic and how we categorize keratoconus in a different way today. In spite of what you heard, in spite of what you read, it's true that the predictability of intracorneal ring segments is an issue. It's an important issue. Second, variability of the outcomes is very much existing, and the reports that you read in the literature are usually based on a small series. So it's much more surgeon's experience or good luck sometimes, but it doesn't reflect, high volumes doesn't reflect the real world. So if you think what is happening in keratoconus, whatever degradation that you have, from it starts, progresses, reaches very advanced condition, but in all this, way, vision is deteriorating. So what happens in keratoconus since the beginning is that you have an influence in vision, and the patient is going to you because of visual loss. And it's true that in different keratoconus that have been proposed in terms of classification, none of them are good enough to fully incorporate all the current knowledge on the clinical knowledge that we have on keratoconus, and none of these ones, including our own classification, is based on the severity of the visual impact of the corneal disease. But you have to think that the patient comes to us, to the office, because vision. Patient ignore pachymetry, key values, or biomechanical data, and quality of life is lost by the patient because of vision. So vision is what matters in this disease, is what matters to the patient, is the reason for the patient to go to your office. This is why some years ago, 6 years, we created this network in Spain, which has been sponsored by the Spanish Ministry of Innovation, in order to get large data collection about keratoconus to know what is happening on this issue. The data I'm reporting to you is the one that we had until 4 years ago. We have now much more many cases, and it's about 770 eyes of 500 patients that were recorded up to June 2011. And the data I'm going to report to you now has been published, and so you can track this through the published literature. So the aim was, number one, to identify the variables involved in the visual loss, Second, to know the outcomes, the real outcomes on the modern techniques to improve keratoconus. And third, to develop new therapeutic algorithms, new treatment methods in order to improve keratoconic patients. So in these patients, we run this protocol. As you see, it's very extensive. We are including everything what is at this moment the state of the art about the knowledge of keratoconus, and we analyze extensively by statistical analysis that I'm not going to mention to you because it's quite extensive and a little bit boring, but we could clearly relate that these variables at this level of statistical significance clearly related with the degradation of vision in keratoconus. So with vision the case, you have a change in the key value, you develop an increase in internal astigmatism, you increase the Riemann square of the coma-like aberrations, and you increase the asphericity towards negative. This is all happening in parallel to the visual degradation in keratoconus. And we created this classification, which is called the Redis classification, that from grade 1 to grade 4 plus, you find cases with normal vision, but they are keratoconus, or cases with very bad vision, and they are keratoconus, but with different changes that happen in internal astigmatism, in progressive increase in the key value, progressive increase towards more negative, or the asphericity at 8 millimeters, and increase in the coma, which basically indicates the asymmetry of the keratoconus. And this is not the same dog with a different color. If we grade this over 700 cases with the Ansler-Krumak traditional classification that, by the way, was described in less than 50 cases, by our classification described in 2006 that is based on the coma aberration of the corneal surface. And the Redis, you see that we classify the patients in a different way. The same group is classified, let's say, similar in these two, totally different in Redis. So we have indeed found a different way to classify keratoconus. This is indeed the main base of this new philosophy, and indeed we have developed this in a very high number of cases. The highest so far is based on the correlation that exists between clinical, paraclinical variables and the patient's vision. It includes parameters such as the analysis of posterior surface of the cornea and corneal barometry, because to measure internal astigmatism means to measure the posterior surface of the cornea. It's the deduction that you make from the total refraction from the anterior corneal surface astigmatism, includes the corneal asphericity of 8 millimeters, not only at the central 3 millimeters. And of course, this classification should allow, as far as we know better, a better knowledge about what we do in keratoconus. And this was published in Journal Refractive Surgery 2011. So everything that has been mentioned here, including the statistical analysis, for those that are curious of you on this, can be read on this reference. So we went to the second stage, which identified the outcomes of intracorneal ring segments. And this is published in 2015, American Journal of Ophthalmology. So if you want to go further, read this article. It would be quite interesting for you, because we have in this series of cases over 500 cases, but I'm going to report to you what happened only in the best case study, which were 114 eyes with the same complete proprietary diagnostic study, same surgeon, was me, same nomogram, same intracorneal resegment, which is Keratoconus, identical to Ferrara, same indication, same femtosecond laser, and with same femtosecond parameters and incision location. And what we got, what a good representation of what is happening in our general classification. As you see, we had few very early keratoconus, more grade 2, grade 3, less grade 4, and grade 4 plus. Grade 4 and grade 4 plus are indication for corneal graft, but as a comparative indication, we did this because the patient accepted this indication just to try. And we define success, because you need to know success by defining the success. For us, success was modest to gain one or more line associated best corrected with gain of one more lines of uncorrected distance visual acuity and a decrease in 1 micron root meter square hydral aberration. So this was the definition of success. Definitely these patients were better than before, were not extremely well, but definitely better. And see what happened. Success was only happening in 13% of the cases in grade 1, 49% in grade 2, 54% grade 3, and grade 4, 81, and grade 4 plus 85. But if you define failure as just the opposite, to lose one line of best corrected visual acuity and to increase the hydral aberration, 51% of grade 1 increase in the problem, 29% get worse in grade 2, almost 19% in grade 3, 9% only in grade 4, and only 11% in grade 4. But if we want to go to a qualified failure and more than 2 lines were lost, look what happened. 37% of grade 1 lost more than 2 lines, 20% lost more than 2, grade 2 lost more 2 lines, only 9% grade 3, 4% in grade 4, and in grade plus only 3%. So this clearly indicates that the outcome in intracorneal resegments is related to preoperative vision. So our classification was useful to improve or not the vision of the patient. And you see here clearly that we have a grouping with, we have no indication at all, but because ethical reasons of intracorneal resegments. So we have a gray line, which is about 0.7 to 0.4. More than 0.6, you have only 37, let's say 38% probabilities to improve, with 36 probabilities to degrade vision. Any of you would have appendicitis surgery with this percentage? No. Keratoconus would not be performed either. With less than 0.4, you have 82% probabilities to improve vision, only 10% to lose vision. Unqualified losses happen in 25% that choose patients with better than 0.6 vision to perform surgery. With intracorneal resegments, only 4% with less than 0.4. So in between grade 0.4 and 0.6 of decimal scale is the art of being a surgeon to decide adequately in the favor of the patient. So now we have in the grade 3 how to decide things, because we are learning from experience. How we learn from experience, we have developed a network, a neural network, to develop a much better and objective approach to the indication of intracorneal resegments. You know that neural network work on data, and we need powerful data, the numerical and demographic data, to have the input-output relationships. We can develop an artificial system of intelligence that could perform tasks similar to those performed by human brain. Learning from experience, we learn for failures and for success, and the more success, we learn more, and the progress obviously lead us to learn even more. And so it is acquired knowledge through learning. And of course, we have the ability to learn these relationships directly from the data B model. We have developing this model as a way to indicate intracorneal resegments. So this neural network has been co-developed by our colleague Heikel Kamun and myself, and has been developed and registered in 2014. The neural network is based on a large number of cases. In this case, we have included several hundreds. You have pre- and post-operative data with vision, refractive parameters, corneal topography, and pachymetry. We have the software that filters the information, providing the best solutions for the case, and gives to you a prediction of what is going to happen. And this is the way in which this is the simulation. This is the case. This is a preparative aspect. We are getting the topography. This is from the CSO topographer. We are loading the data from the pachymetry, from the refraction, uncorrected and best corrected vision, and aberrations. And this is the analysis that the software is making, is selecting the cases that are more similar to this according to these parameters, and finally offers to you the solution in this way. You will see here which is the expected topography to happen with this solution. This is the solution of this to this case, to implant this ring in this position. This is the case, these are the cases more similar to this one of the network. And we are now getting, excuse me. Okay. And so according to this, we should have 0.8 from 0.3. We should have this topography as final outcome, and obviously we need to know that this is true by the homologation. Homologation means we need to see the correlation between the expected outcome and the real outcome that has happened, something that we are at this moment working. But look how useful should be to have the vision that the patient should have with the refraction that should be at the end, okay, and following the implantation of a given ring in this case. So this is pre and post-op with expected refraction from plano to -4, so we increase here the sphere, we decrease the cylinder, we increase the vision to more than double with this impact. So for the first time, we could have surgeon decision to be guided based on artificial intelligence system, by clinical experience. Obviously, you can load your own cases, so the more you introduce, the better is your experience. It's your own experience, but obviously, we can increase it from the network because we're loading this system with more and more cases. And this should be, in my opinion, a very important therapeutic tool in the hands of the ophthalmic surgeon to improve keratoconus treatment and intracoronary resections. And I thank you very much for your kind attention.
The next topic is treating ICRS complications, and Hani Sakla is going to guide us on that. Hani Sakla.
Thank you, Dr. Anwar. I'm really privileged to speak after Professor Alio. I was very lucky to be one of his international fellows more than 20 years ago, and I owe him a lot, and what I am today is thanks to him. I'm going to, I believe my talk is going to be easier after his lecture, that it showed how complex and how complicated it is to master the art of intracorneal ring segments. And I'm going to talk today about the complications of intracorneal ring segments, regardless of the type of the rings, Intex or Ferreira or Kera rings, and regardless of the techniques, is it with the femtosecond or with the manual technique. There is a published study also by the team of Professor Alio, which is very important regarding the complications. It's a multi-center study that looked into the cases of the explanted intracorneal ring segments in 9 years. And it was found that almost 50% of the extruded cases was due to spontaneous extrusion that needed explantation of the lenses. And 10% of the implanted cases were extruded in 9 years' time. This is, I believe, because the corneal ring segments does not halt the progression of the keratoconus. The cornea continue in its thinning pathology, and the ring reaches the surface and gets spontaneously extruded. Here, these are some of our cases with spontaneous extrusion. The second most common complications that needed explantation is the refractive failure. We have seen in the presentation of Professor Alio that the successful depends on the surgeon and on the nomogram. Still, there is no very well developed nomogram that make this procedure predictable and reproducible in our hands. So refractive failure was responsible for almost 37% of the explanted cases over 9 years. Then there are other complications like corneal neovascularization and the deposits around the segments. Corneal neovascularization sometimes leads to lipid depositions and loss of the corneal transparency. Infectious keratitis, it is reported in the literature that it is up to 1.4% of the cases of corneal ring segments develop infectious keratitis, and it is a devastating kind of keratitis that might lead to endophthalmitis. The incidence of 1.4 is a very high incidence for infectious keratitis in any ophthalmic procedures. Then corneal perforation. Corneal perforation can be intraoperatively, it can be anteriorly, like here, or it can be posteriorly, like the case that we see up that happened intraoperatively that led to injury to the iris and the development of cataract intraoperatively, and the patient had to be transferred to an OR as an emergency case, and we are going to see how it was managed later. Again, spontaneous extrusion we can see in this here. Other complications like edema, like shallow placement, like cell deposits, like corneal opacities. So what is the management of all these complications? The management, first we have to decide. The most important thing, as Professor Alio mentioned, is this, from the point of view of the patient, is his vision. So subjectively, we must study the complaint of the patient. If the patient has experienced some improvement in his vision, then we must entertain the idea of keeping his rings in its place. Then we should look at if the rings are at a proper depth or not, well centralized or not, and if the patient had underwent cross-linking before or not, then we would consider keeping the lenses, and we will see how we are going to solve his visual problems later. But in other cases, if the patient had lost some vision, or he's not happy with his rings, or he did not gain anything, or the rings are not in the right position or depth, or not well centered, then we have to explant this. And we can see in the literature that about 22% of the implanted rings were explanted worldwide. This range is 9 to 30% according to the literature. We can imagine if this is the case, for example, with any IOL, that we explant 1/5 of the cases, then we would abandon this technique definitely. So keep the rings, and then we should do either cross-linking alone if the vision is good, or topo-guided PRK with cross-linking if the vision is not that great. Then plus or minus toric ICL depending on the residual refractive error. If we remove the rings, then we wait for 2 to 3 months till the preoperative topography is recovered. Then we can do topography-guided PRK with cross-linking or toric ICL, or in extreme cases, keratoplasties. So the guidelines, as I have just mentioned, with the segments, if it is stable, the eye is white and quiet, the patient is happy with his vision or recovered some vision, there is enough stroma in front of the rings, well centered, then we'll keep it. And after explantation, then we must make sure to make topography-guided PRK that the residual stromal thickness or the residual corneal thickness is not going to be less than 400, so it should be more than 450 before we treat this patient. If the age is above 40, we can do, or we can ignore doing cross-linking according to your discretion and your decision, depending on your region and the natural history of the keratoconus according to you are in Europe or here, because here there is no age for the cessation of the progression of the keratoconus, and it presents at any age. So after explantation, we wait for the pentacam to recover. Now I'm going to show you a few cases how we managed. This is a case of a young lady, 30 years old. She had intacs in 2007 in both eyes. Her uncorrected distance visual acuity was 0.3 in the right eye. In the left eye was only counting fingers 3 meters without any improvement in the left eye. But in the right eye, it could reach 0.5 with a small cylinder. This is her pentacam. And we can see here on the right side, she has more or less regular astigmatism with the presence of the rings, while in the left eye, with the vision is very poor, and the keratoconus is advanced. Then we decided to do topography-guided PRK for the right eye with cross-linking and the keratoplasty for the left eye. We did OCT for the cornea. We don't have intersegment OCT, but we have the option of corneal OCT with the Cirrus from Zeiss. So we did for her keratoplasty for the left eye in February 2010, and the topography-guided PRK without intact explantation. We left her intact because she had regular astigmatism and reasonable vision in April 2010. This is after the keratoplasty in the left eye, and 6 months after the keratoplasty, her vision the uncorrected distance vision was 0.1, the corrected was 1. And here we can see this is after the keratoplasty, the before and after the keratoplasty in the left eye, and this is the right eye. This is the treatment plan. So we put her pentacam images in the software, the TCAT software of the Allegretto IQ 400 Hertz, and we planned the treatment according to that, making sure that the stroma after the treatment is not less than 400 microns, and we try to correct up to 70% of the existing astigmatism that she has. And we know that this topography, as I mentioned yesterday, this topography refraction is the induced astigmatism from the treatment. This is what is going to be to get the patient after the treatment due to regularization of the irregular astigmatism that she has, but she would get better vision with this astigmatism, even though it is even more than what she had before. So this is the treatment plan from the machine, and this is our normal protocol that we do it. We remove the epithelium with the Amoils brush, and we do the treatment over 5.5 millimeter optical zone. And this is the result. We followed this patient up to 4 years. We can see here from 2010 to 2014, and we can see that it is very stable, and the epithelium healed in these patients usually very quickly. And after 1 month, her uncorrected distance visual acuity was 0.5. The corrected distance visual acuity was 0.6. After 4 years, still she's maintaining the same visual acuity. Uncorrected distance visual acuity 0.8, and the corrected was 0.9 plus. Then, keeping the rings and doing topography-guided PRK, cross-linking in another patient who had rings in both eyes. This is a 32-year-old male, and you can see the right eye here, the vision is only 0.2 without improvement. After 3 years from the topography-guided PRK, his vision uncorrected was 0.3, the corrected was 0.7, which is 3 times better than what he had before. And in the left eye, the uncorrected was 0.5. After 3 years, it was the uncorrected 0.5, the corrected was 0.7. In this particular patient, we had to do this, although I would have preferred to remove his intacs, but because he lives from, he came from overseas and we had to solve his problem in a very short time, he didn't have the time to stay here till he is recovering his preoperative topography and doing the procedures. But he has a good, useful vision. We can see here in the right eye that it is only sphere, although we can see in the pentacam that there is a cylinder, but sometimes in keratoconus patient, refraction is very difficult, and we have to do a manifest refraction for them, because sometimes it shows that in the autorefractometer that they have a cylinder, but they can see even better without this cylinder, or much less cylinder than what is showing there. Another case that needed removal of the rings, and then we did topography-guided PRK. In this case, we removed the rings and we did a PRK, and the patient improved a lot. Another case here that we did after the topography-guided PRK and the cross-linking, a toric ICL 2 years after the TCAT PRK to correct his residual refractive error of +4 and -3. This is the case that I mentioned in the beginning. She came to us with this polychoria with multiple injuries in the iris. We put for her this Morcher ring to correct her dysphotopsia. The last case, or the conclusion here, is that corneal ring segments are still associated with high morbidity and high incidence of complications. However, most of these complications can be fixed with topography-guided laser treatment, or in the worst case with keratoplasty, leading to recovery of the lost vision. Thank you.
Thank you very much, Dr. Hani. I think the issue is clear. Can we shift the gear now to keratoplasty itself? And the first talk is global demands for corneal transplantation. How can we meet the needs? Dr. Richard Abbot from Bascom.
Thank you very much, and good afternoon, everybody. It's a pleasure to be here in Abu Dhabi. Since we're moving into a discussion of keratoplasty, I'd like to just kind of give an overview to you about some of the global demands and some of the challenges we have, and how we're going to use some of the new innovation to meet this demand. This is my institution at the University of California in San Francisco. So the magnitude of global impairment is significant. And if you look at these statistics, 2004 compared to 2010, you can see that we've made some dent, going from 314 million visually impaired down to about 285 visually impaired. These are statistics from the WHO, so a drop of just under 10%. The problem is the total population, however, has grown from about 6.2 billion to about almost 6.8 billion. So there's been about an 8% growth in population, and that, in fact, the population over the age of 50 has grown by almost 20%, and this is where we see a lot of the need for keratoplasty and preventable blindness. If we look at this pie graph and the causes of blindness, you can see the blue area is cataract, and that's what we all would expect. And undetermined is the next largest, which is about 20%. And then you can see cornea is about 4%, about the same as age-related macular degeneration, refractive error about 3%, glaucoma about 8%. If we then look at this chart and look at the regional variation in causes of blindness and diseases responsible for blindness in developing countries in particular, they're different from the developed nations. And if you look specifically at the cornea scar trachoma area, you can see in this region that this is a pretty significant cause of blindness at about 20, 25, almost 26%. So pretty much the highest in the world. And then also in this region, very significant is cataract. This graph shows the corneal blindness by countries. And what's interesting is that 15 countries in the world represent 50% of the global burden of blindness, with high incident rates in the blind population. And just looking at this map, with red color being the highest prevalence, you can see that Africa and India are very high, and then right behind that are countries from this region as well as China. The causes of corneal blindness are many. These are some of the leading causes, including trachoma, and you can see a photograph of an Aborigine from Australia on the right, vitamin A deficiency, corneal infection, of course, ophthalmia neonatorum, trauma, and other causes. Most corneal blindness is avoidable, and it's preventable and treatable, and about 95% of it. In looking at programs that are developed for prevention and health promotion, the SAFE strategy in trachoma, involving the use of surgery, antibiotics, clean faces, and environment, is a major preventative method, as well as supplementation with vitamin A, measles vaccine to prevent the keratitis, better perinatal care, public education, improved education and training for our residents, and then improved care, both primary and secondary, as well as tertiary. So in the education mode, ophthalmology training is, there's a huge initiative for that. The International Council of Ophthalmology, the ICO, the American Academy, and many other international organizations are very committed to improving education and training so that this problem can be dealt with. So the treatment for all this corneal blindness is corneal transplantation, and now we have not only penetrating keratoplasty, but several new procedures. Corneal donations and transplant statistics, about 60,000 total corneal grafts were supplied to the eye banks in the United States, and about 46,000 corneal transplants were performed in 2012, and many of these extra corneas were sent internationally since there is such a significant global need. The number of cornea donations in 2010 were over 110,000. These are statistics from the Eye Bank Association of America. The challenges, I think, globally for eye banks are to increase the number of donors, to look at the recipient pathology and the success rate, and develop better and more innovative techniques to treat some of these severe conditions. And then once the surgery is done, to maintain good quality care for these patients. For the eye banks, the challenges specifically are to maintain the quality of the eye bank, increase the quantity of the tissue supplied, and then to provide these networks. And there are many networks now among the eye banks, so that if tissue is available in one region, or there's an oversupply and another region has a need, the eye banks now, through their networking, can supply these tissues and distribute them better than in the past. So here is that slide I showed you before of corneal blindness with a very high prevalence in the Middle East region and Africa and India. And then I'm going to show you a slide of where the eye banks are located. And if you look at this, you know, where the need is greatest, we have the fewest eye banks. If you can see in the Middle East, in this region, a relatively low number of eye banks. The only place that really has made a difference is in India, where Nagrao and LV Prasad and Aravind have really stepped up and really helped answer the problem with more eye banks and more donor tissue available. Unfortunately, in China, where there is a need, this has not occurred. There is a global alliance now of eye banks that internationally is an internationally recognized association of eye bank associations, and so there's a lot more communication, and I think this is very helpful. And also at the World Cornea Congress coming up in San Diego in April, there's sponsored by the International Council of Ophthalmology. There's going to be a discussion on the first scientific meeting about global conversations in eye banking, and I think there'll be representatives from many of the eye banks around the world to figure out how better to get tissue and distribute it more efficiently. More challenges for the eye bank include public awareness to increase donations. Hospital grief counseling is critical. And in many countries where legislation has not been passed to increase donations, this also is being worked on. So I think there are many, it's a multi-pronged attack to increase our availability of donor corneas. We also need better trained personnel. We need standardization for the medical procedures and the classification and use of this tissue, accreditation of the eye banks, and put in place all these systems. Here's just a recent article from Canada where it says the corneal transplant system in Canada is broken. And there are many problems, even in developed countries, where the eye banks are not working the way they should, and there's some criticism. So I think this global conversation at the World Cornea Congress is going to be very helpful to deal with some of these issues. So let's look from 2015 to 2020, and you know, we have the IAPB, the International Agency Prevention of Blindness, has an initiative, the Vision 2020 initiative, and so those of us in the field of cornea are looking at how do we help achieve this goal to free our patients of avoidable corneal blindness. So I think this will be achieved with a lot of global partnerships. There's a lot of effort between the public and private sectors, translational research from our labs into clinical practice, with using a lot of innovative ideas and models, and you will hear more and more about this at this meeting and other meetings, expansion of modern eye banking, and a very focused approach. I just want to say a few words about innovation, because this is a very, very key principle. And I think, first of all, the definition of innovation, and that is to make changes in something that's established, especially by introducing new methods, ideas, or products. It's different than inventing something. It's taking something that's established, and through innovation, change the idea or implement a new idea or thought. So innovation differs from invention in that innovation refers to the use of a better and, as a result, novel idea or method, whereas invention refers more directly to the creation of the idea or method itself. And what many of us are doing, and many of the clinicians here in this room are doing, is innovating, taking ideas, taking surgical procedures, taking concepts, and applying them clinically to give us better options for surgery. So here you can see just photographs of many global citizens who are in need of corneal transplantation and innovations such as artificial corneas, keratoprostheses, and other technology will help us achieve vision for these patients. So through innovation, research, and translation to clinical challenges, we will meet this global demand. So thank you very much for your attention.
Thank you very much for dealing with a very complex issue and very necessary one. The next talk is DULC is the best for moderate and advanced keratoconus, and this will be sorted out by El-Danasoury, please.
Thank you, Dr. Anwar. Ladies and gentlemen, in the coming 10 minutes, I'm going to share with you the result of our work at the Jeddah Hospital with DULC for moderate and advanced keratoconus. I have no financial interest in the subject of this presentation. This picture goes back to 4 years ago, when we had, when we recognized Dr. Anwar. That was in Dubai, in Abu Dhabi 2012, when we recognized Dr. Anwar for his service to the Maghrabi hospitals for over a few decades and few more decades to come.
Thank
When we treat keratoconus, when I have a keratoconus patient in my office, I believe that whatever we have with the new toys that we have in the office, very friendly, very easy to use, aberrometers and topographers, but there is one that we always miss, which is the human brain. The patient is the one who is seeing, and he is processing this image, and he knows better than any topographer or aberrometer if the quality of vision he is seeing is enough for him. So that's why in my practice, the longest chair time I have with a patient is on the first visit of a patient with keratoconus. Because I want to know and to understand clearly, without any doubt, whether the vision that this patient has with his spectacle correction, is it acceptable for him or not? If you just ask him a casual question, are you happy with your vision? He'll say no, I want a better vision. But you need to explain to him that he had got a corneal pathology. And we cannot guarantee that he can see better than what he's seeing. If he's seeing 20/25, then his expectations come down, and you need to reach a good understanding of what the patient sees. Of course, with the topographer and the aberrometer, you can reach a decision with the patient on what is best for him. If the patient have an acceptable vision, then I will not go for aggressive surgery. If it's stable, we're going to do aphakic lenses, as I said, or keep him on his glasses if he prefers. If his pathology is progressive, then cross-linking is a safe procedure. Then after stabilization, we still have the option of correcting his refractive error with a secondary aphakic intraocular lens. If the patient has an unacceptable vision, then we go for rigid contact lenses is always an option if the patient tolerates it well and if he has good vision, that there is no, of course, no objection in using this. But in most of our cases, in our region, patients do not tolerate hard contact lenses. In this case, I go directly and straightforward to offer DALC, even if the keratoconus is moderate or not very advanced. Usually when we do the DALC, we remove the sutures 1 year later, and then we can offer a secondary procedure if needed. I've done many intracorneal ring segments for keratoconus. I'm not happy with the outcome. And if you remember, if you go back to the late 90s, the ring segments were introduced for correction of myopia. And that was a big boom. And the company was really booming at that time, and the stock market were very high. Because it can correct myopia up to 4 diopter with preservation of the quality of vision, reversible technique, and I was part of this. And then we realized that it's not predictable at all, and no one is doing this for myopia now. Then came our dear friend, the late Joseph Collin, and he actually saved the intracorneal ring by publishing his results with keratoconus, and we thought that it stabilized and improve the corneal topography. And we lived for a few years with mixed results, stabilization and improvement. Then a few years later came Theo Seiler with the cross-linking. And then we really knew how the keratoconus can be stabilized with the cross-linking. Then all of a sudden, corneal ring surgeons said, okay, now we're going to do corneal ring and cross-linking. So if the corneal ring stabilizes, why are you doing cross-linking? And I was asking this question for many years, and I didn't get an answer yet. Nowadays, many people think that corneal ring segments improve the corneal shape. It does sometimes, but I really fail to know when are these sometimes. And I know at least 4 or 5 very good friends, very good surgeons. Each of one has the best nomogram for intracorneal ring segments, and they are getting good results with totally different nomograms. So to me, the intracorneal ring segments are unpredictable, have mixed outcome. We don't see published in peer-reviewed literature long-term results. The only publication I know long-term was from Paulo Ferrara, very few number of eyes. And to me, the most important drawback of intracorneal ring is that it decreases the chances for big bubble DALC. You might have a perforation during the ring. It decreases the chances of having a smooth and easy surgery. On the other side, When you go to the big bubble bulk, I'm going to share with you the results of our prospective study on a good number of cases, 105 consecutive eyes, and we studied this patient for 18 months. Steps are already known: partial terephination, bubble, debulking, puncture, exposure of desmet, and the removal of the stroma. And can we play the video? And then I'm going to skip this. I think you saw too many. I'm going just to show you the bubble if it shows here quickly, because I'm sure you've seen a lot of this in this meeting. So here I'm using the Moria single-use Terrifine. I like it. It's an adjustable Terrifine. It has the best suction because it's on the limbus, not on the cornea. It gives you vertical cuts because it has this obturator in the center, so you're fixing the cornea from the center and from the periphery. So you're cutting in between. So your cut is vertical and very nice and clean cut. And then with the 27 gauge needle, I go as deep as possible and then inject a bubble. In most of the cases, you get a bubble from the first time, and then if not, you can apply a second, third try, and the rest of the procedure is easy. Removing the desmet membrane and then suturing the way you like. I use continuous sutures, but you can use the technique of your choice. At 1 year, we remove the sutures if the cylinder is high, more than 4 diopters, after we do all our adjustments. If the patient has an isometropia, I cannot use glasses. If there is suture-related complication, or if the patient needs a further refractive surgery, then we remove all the sutures. We have a follow-up rate of pretty good follow-up rate, more than 90% at 1 year. These patients usually come for their follow-ups. Looking at the uncorrected vision over 18 months, the vision was pretty good. This is in logMAR, visual acuity 0.5. Uncorrected. More important is the corrected vision, 0.15 and 0.12 at 1 year and 18 months. This is a very good vision. Refractive cylinder was an average of 3.9 at 1 year. When we removed the suture, the cylinder increased in this group with the suture removal. When we kept the suture in place, it did not change. So that's why we do not remove the suture unless really needed. This is the vector analysis of the change of astigmatism after removal of suture. There is a change. The change is unpredictable. So I tell the patients, if you remove the suture, 3 things might happen. Your vision might improve, your vision might stay as it is, or your vision may get worse. So bottom line, I don't know what will happen. So I don't remove the suture unless I really need to remove it. We looked at all the corneal indices at 1 year and 18 months, and you see that there is significant improvement in all corneal indices. The main adverse effects we got in this group of patients was a failed bubble in 9% of the cases, so we got a big bubble in 91% of the patients. Microperforation 6%, near desmet dissection 5 eyes, and most importantly the stromal rejection. I was really surprised to see. I thought this is very rare, but we had almost 6% cases with stroma rejection, and all these cases resolved with topical antibiotics. So to conclude, we do believe that the big bubble is effective, reproducible, and very safe for the surgical correction of keratoconus. Keep in mind that the refractive change after removal of suture is unpredictable, and in case of good refractive outcome after DALC, it might be advisable to leave the sutures as long as you can, as long as there is no indication for removing the sutures. And I thank you for the kind attention.
Thank you, Alaa. Now, we have once again Jorge, and he will tell us how to use femtosecond laser-assisted corneal graft surgery.
Hello, this topic we deal with in continuation with what Alaa mentioned is about corneal graft surgery, in this case, penetrating and non-penetrating assisted by femtosecond laser surgery. We have problems with the conventional grafting technique, which means the manual ones, First of all, the size and the shape of the donor and the recipient is imprecise, particularly in keratoconus, because we are dealing with different surfaces, with different curvature, and definitely they have a not precise outcome in terms of how much you will get. The good configuration is variable because in spite of how vertical or not you are, you cannot predict what you are going to do, and basically this leads to a donor-host interface which is also unpredictable. For this reason, wound healing consistent is unpredictable because sometimes the thickness of the cornea will be thicker or thinner. The refractive outcome as a consequence will be very affected by all these variables, and of course will cause trauma to donor tissue, especially in penetrating keratoplasty that is uncontrolled because many times you lose the anterior chamber and then you penetrate the eye and you damage the iris. Which is the value that we could find in the use of femtosecond laser on cornea graft. First of all, the accuracy in size and shape of the donor and the host decision should be almost total, complete control on what you do. You can customize the wound configuration, and we shall see this immediately, to promote a better donor-host tissue interface and contact. And believe me, this is true, and I will show to you evidence that this is happening now. There is an improved control on the suturing technique, definitely yes, because you have landmarks in order to place the sutures deeper or in the right place. And as a consequence of this, we should have a control in wound healing that should be improved as well. We have in femtosecond assisted penetrating keratoplasty profiles. The ones that are in zigzag offers the advantage that you have more donor-host tissue one in from the other, and as a consequence, you have a larger area of healing. Femtosecond dark with the same issue, with the advantage indeed that you remove most of the stroma, even going even larger than the deep surface, in order to avoid the peripheral parts of the cornea and to avoid chances of perforation. And there has been a proposal to perform femtosecond disc, so far not successful because we don't have the precision to have very thin flaps, and then the visual recovery is delayed in these cases. Most of what I'm going to tell you has been published by me and my collaborators in this very year, in this book, Femtosecond Assisted Keratoplasty, edited by the IP Brothers, and you can find it in the web or in the library of your choice. So the femtosecond laser we use is the intralaser. I have been using the Alcon femtosecond and also the one which is the Visualize, the size. But this is no question the best in terms of software and performance, and is an ideal adjuvant for us, or for me, to get a more advanced type of cornea surgery. We have more precise regular cuts. We don't invade the eye, and you saw before in my talk about combined cataract and cornea graft that we can even perform cataract surgery with a pre-cut cornea. We have perfect donor recipient size matching, and there's no way to make any mistake. You see what you do. The injured donor endothelium is non-existing because basically it depends on your hand at the very end of the procedure. We customize the cut pattern depending on the case. We have more donor host tissue apposition, potentially less astigmatism. This is a problem, and we'll talk about this today as well. We should have shorter rehabilitation time and a stronger, more stable wound, and as a consequence, early suture removal. These are the customized cut patterns. We use the zigzag and modify one of the zigzag, which is the boat, and this is something that you can do only with the intralaser because these patterns are only available with this device, the one that I recommend for this purpose. Okay, let me go. I want to skip this because it's not necessary. Okay, and these are the patterns that you can make among many others, but basically what you try to get is more surfaces to get a better contact. This is very good because it's like making a cork in the head of a bottle, because you can screw the cornea donor onto the recipient because of this tone that you have here, and the monstrum really makes you to have as much cornea as possible from the top, which is the area in which you have the problem of the keratocytes and the problem of keratoconus, and then to leave the posterior surface just in the area that you really want to excise and to go as deep as possible in the cornea. So the consequences are improving in all these parameters, faster recovery, better astigmatic outcome in cylindral regularity, and early suture removal. So let me show to you our experience with the zigzag technique in one very case that is impossible to be done with normal grafting techniques. This was a case of a 20-year-old female with acanthamoeba. She had a central microperforation here, and the corneal perforation was a contraindication for keratoplasty. Obviously, you if you make the suction, you will empty the eye. But what about this case? Is this a contraindication? Look here, the Seidel test. This is the fluorescein, and here the fluorescein few seconds after. This eye was perforated. No way to do a controlled penetrating graft, in this case with manual technique. And look what we did. We didn't use anesthesia because we didn't want to increase the pressure in the orbit. And so on the topical and with a lot of care, 20 years old female girl is very uncontrollable, very nervous, but we put some viscoelastic here just to tamponate internally. We use Hilon for this purpose. And then look how we could get a good apposition of the cone of the intralace, blocking the opening of the side of the decimator cell and making in this way the work. Look, you will see very clearly that we get a little bubble of the visco, but then it's immediately stopped by the pressure of the cone. And in this way we could customize the size and the pattern. We use the zigzag pattern, going very far away in order to eliminate as much cornea as possible, because we were dealing with acanthamoeba and we didn't know where would be the limits, but definitely we decided to be like this. And with the zigzag, we can leave area to heal more than with the other. You look here, the different circles that we are creating, and we have 3 cycles here with the 3 different surfaces to promote wound healing. This was the moment in which we ended the procedure. As you see, we have not lost the anterior chamber, we have minimal leakage from the visco, and now we are going to enter into the eye in a controlled way, in the way that we want, selecting this. Look that we have been not losing anterior chamber at all, and this is the initial visco substance that we use, and this was the aspect of the eye. So this was the post-operative appearance, very good. And what was the outcome? You see here the case. As you see, we have a very good profile, and this was taken about 2 weeks later after the procedure. And the post-operative was very good. There was the outcome, 2.5 of astigmatism, very good vision at the end of the 2nd month. The pattern proved to be with excellent stability, and indeed this proved to have the advantages that we expected to have theoretically in these cases. So what about DALC? Because we're dealing with deep anterior lamellar graft. In deep anterior lamellar graft, we should access as much cornea as possible, because remember, we leave keratoconus disease in the recipient, and this is one problem that leads to recurrence. The position of the donor-host interface should be very large in order to promote wound healing. And of course, in this case, as you have 2 clear and well-defined planes, you can identify the deep resection for the big bubble technique that we are using, thanks to Dr. Anwar, who is present here. Different corneal steps can guide you better in the surgical technique. To do this, you need tomography. Tomography is very important in keratoconus because it's not about a focal point in the thickness. You have the whole area, which is the subject of different disease. Look here, this keratoconus case, this is the tomography. Indeed, you need to know how deep you are and to select adequate pattern and the depth in which you are going to be. And the purpose is to leave stroma behind capable to be resected by the big bubble. So we never go to stroma surface, because in case that we do, it is going to be regular. So we use only the intralace for the side cut. The side cut is totally feasible, and this is what we do. We do what we call the super Mosron technique. Now we are going a little bit deeper than this in order to take as much stroma as possible and to go smaller inside in order to decrease the chances of penetration, because most of the cases in which we have had troubles on penetration have been in the periphery. So these are the different diameters that we use, the different thickness. This is the profile. This is the super Mosron approach. And we have a disparity of 0.6 and a total size of 8 millimeters deep. We try now to have this smaller, keeping the outer diameter as much as this, and you get exactly what you want, and this is the aspect of the eye after one of these grafts. Okay, and these are the proportions that we leave in this profile. We do exactly the same in the donor, when we use the Moria artificial anterior chamber. And this is our experience in DALC. And I have to tell you that most of the expectations that we had have been accomplished, but going through the data, and remember, medicine is a science, and we need to know data and to analyze data in order to prove our performance. And we couldn't demonstrate that the patients dealing with manual and femtosecond had a better best corrected visual acuity at 6 months. kind of disappointing that we didn't improve the vision, best quality vision, being so precise and so sophisticated. About the differences at 1 month, 6 months, and 1 year were about the same. At the beginning, we had a trend towards better with femtosecond, but basically at 1 year, the results were about identical. And look here about the corneal cylinder. We didn't get better results. The trend was for manual and femtosecond to be about 4 diameters of residual astigmatism with a standard deviation of 3, slightly less in the femtosecond, so definitely there is a trend towards less astigmatism, but indeed, as you see, the variance is really, the range is about the same in both cases, a little bit more with manual, but this statistic didn't reach statistical significance. So this is kind of disappointing. We're doing better for nothing. This is about what happens with femtosecond cataract surgery. Let me tell you now what happened. And I think that we have identified the problem. This has been submitted for publication this week, so you can read it. In case that is accepted, will be in cornea. And look what happened. We have different amount of wound healing pattern. And wound healing pattern is better, definitely, in femtosecond, according with the grades that we were using in this study. And we have larger wound healing that is detectable at the slit lamp. Let me show it to you. These are the healing patterns that we have, and according to these healing patterns, we see that clearly this is related to the profile and to the activation, biological activation of the cornea by the femtosecond. This is the scar typical in a manual case, the scar typical in a femtosecond case. It's bigger, is following even the stitches. You see that the stitches are impregnated by the scar that is developed by the increase of activity of the keratocytes. So wound healing is activated by femtosecond, is promoted. As it is promoted, you have a larger area of healing, and as a consequence, you have a glaucoma. So we need to take a lesson from here, and the problem is that you have to grade in the slit lamp, how is the patient going? Probably in grade 2 to 3 is when we need to remove the stitches. If we remove the stitches properly in an adequate stage, we have not this trend because it's promoted by the presence of the stitches, and we stop about here, probably that leads to less activation of the wound healing. Probably we can remove about 6 months after surgery the stitches without promoting any problem in the cornea in terms of ectasia, but decreasing the negative cosmetic impact of the wound healing, having all the advantages of femtosecond. We are in the way to prove this now, and what is the only problem is that you are with a disease in the peripheral cornea. So whatever is the matching that you do in the donor and the recipient, you have the peripheral cornea which is weakened with a different resistance, and probably this is a limitation for the astigmatic outcome. But then let me tell you that when you do this, in other cases other than keratoconus, our outcomes are better. Again, I invite you to go to our book about this topic, and I thank you very much for your kind attention.
Thank you, Professor Jorge. The next issue requires audience to vote. Is it before the talk or after? Anyway, El-Danasoury is going to sort out the simultaneous EK and FECO. Now? Here it's listed like that. Oh, yours back before. I apologize. Please come on the podium. Okay. You seem to be worried, will PK still exist in the future? And after Richard's talk, I think the answer is obvious.
There's no.
Okay.
Good afternoon. I think since the evolution of the endothelial keratoplasty and the deep lamellar anterior keratoplasty, the number of penetrating keratoplasty worldwide is now decreasing. So I'm trying to see if it can exist in the future or live. After Dr. Alio and Dr. Alaa mentioned that about the selective keratoplasty, either the endothelial keratoplasty with the pros and cons. So the endothelial keratoplasty is strong wound, maintain corneal curvature, faster visual recovery, no suture, closed anterior chamber, so less complication. But the cons is there is endothelial trauma, dislocation of the graft, and there is some literature publication about the endothelial cell count compared to penetrating keratoplasty. And this was mentioned before in the past presentation regarding the type of endothelial keratoplasty. And it is a beautiful surgery. The patient has very fast visual recovery, but there is drawbacks, as mentioned in this slide, that we see this dislocation and persistent corneal edema and graft failure. Another case with the complete dislocation of the endothelial graft. Regarding the anterior keratoplasty, either partial anterior lamellar keratoplasty or deep anterior lamellar keratoplasty, the main advantage is no endothelial rejection, which is the common rejection that we face when we have corneal graft transplant. It is a closed anterior chamber, so no complication by the open sky of the penetrating keratoplasty, but it is technically challenging. You need learning curve for a long time to master. There is an interface haze, especially if you did the anterior lamellar keratoplasty with residual stromal, but if you achieve the deep anterior lamellar, you don't have this interface haze, double anterior chamber. This is the picture of how to reach a good bubble. About penetrating keratoplasty, it is a straightforward procedure, no special equipment, easy access to intraocular procedure, but the disadvantages are many. Open sky procedure, longer visual recovery, change in corneal curvature, weak wound, wound dehiscence, unstable wound curvature, so many problems. And this is a very nice outcome if you are lucky in doing this kind of procedure. Dr. Alio mentioned about the femtosecond penetrating keratoplasty versus the traditional one. And the main advantage of the femtosecond is the strong wound, so there is early suture removal and stable vision. But it needs, it is an unfamiliar technique, more timing, expensive equipment by having an intra-laser or femtosecond laser. This is mentioned before in the previous presentation about the type of the cuts of the femtosecond. So when PK is still indicated, when there is any significant stromal and endothelial corneal pathology, and there is some indication for eye or patient-specific condition where selective keratoplasty, either endothelial keratoplasty or deep anterior lamellar keratoplasty, is not ideal. So penetrating keratoplasty is still good when you are treating anterior and posterior corneal pathology at the same time, like combined Fuchs dystrophy and keratoconus, perforated corneal ulcer, chronic endothelial edema causing haze or scar, full thickness scarring and endothelial decompensation, and if you have any traumatic large center corneal full thickness laceration scar. Like here, sorry. Can I have the slide again? The photo on the left side, you have perforated corneal scar. The one on the right side, you have corneal scar with endothelial edema. Still, the penetrating keratoplasty, if you have severe infection like the Pseudomonas keratitis or fungal keratitis, also still good if you have central corneal laceration or Fuchs corneal edema and scarring. Also, it is easier to do it if you have any decompensated cornea with anterior chamber IOL or macular corneal dystrophy with low endothelial cell count, so you do the penetrating keratoplasty. Penetrating keratoplasty is still a good procedure on eyes with endothelial failure and anterior chamber IOL, anterior tube shunts, aphakia, aniridia, phakic eyes with clear lens, but there is some publication and some now experience about doing these difficult cases with even endothelial keratoplasty. One of the advantages of keratoplasty, penetrating one, is the easy access for intraocular manipulation as cataract extraction, IOL exchange or implantation, pupilloplasty, sutured IOL. Generally, less trauma to the endothelium than the endothelial keratoplasty procedure. This is the photos for keratoplasty together with shunt procedure for glaucoma. And regarding the vision-wise, penetrating keratoplasty equal to a deep anterior lamellar keratoplasty if you achieve the big bubble during the surgery, so you don't have any interface haze, so the vision is equally, and this is mentioned in all this study. They mentioned that there is no difference in the best corrected visual acuity in both penetrating and DALK. DALK is better than PK, as I mentioned before, no endothelial rejection, less endothelial cell loss at 1 year, which mentioned in ophthalmology 2011, less endothelial cell loss and long projected lifespan of graft in ophthalmology 2012. Regarding the PK is good, regarding the outcome, long track record, no interface issue, probably better quality of vision than some lamellar procedure, can readily, can modify many refractive errors with laser refractive surgery. Compared to endothelial keratoplasty, less endothelial cell loss during the procedure, especially in the learning curve, fewer post-operative intraocular manipulation, no pupillary block, and low primary graft failure and graft dislocation. Resource, no need for special basic equipment or special pre-cut tissue, especially in small centers or unequipped one. No need for backup tissue. No need for expensive femtosecond laser, low-cost procedure. So the general penetrating keratoplasty indication, either significant stromal and endothelial disease, keratoconus with hydropes, although Dr. Anwar is still doing lamellar keratoplasty in cases of hydropes, full thickness central laceration scar, corneal perforation, specific eye condition. And this is a 17-year-old keratoconus with hydropes, and this is after surgery. Another 65-year stromal scarring and endothelial edema. So to conclude, while selective keratoplasty, either endothelial keratoplasty or the DALK procedure has definite advantage in many patients, it is not for every patient or every eye. Standard PK is a straightforward procedure that does not require additional expensive equipment, but if you have the ability to have a femtosecond laser, the result will be much better. PK is still a very good procedure for certain indication. And thank you very much for your kind attention.
So now is the time to vote for the issue of EK and FECO, whether you should do it simultaneously or in a sequential manner. So the audience has chance to wait. Is that it? Oh yeah, okay. About E, not much difference. Dr. Alaa will sort it out.
Yeah, no much difference. I'll try to make a difference here.
Okay.
Okay, can I have my slide, please? I know that was uploaded for Saturday. Okay, that can work. But can you go back to the first slide? Yeah. Okay, so I know it's late. We're a little bit late. Is anybody awake in this room? Very few people. Okay. So if you need to stand up, take a deep breath, because I'm going to speak here for like 45 minutes. I started doing DZAC in 2005 after I visited Frank Price in Indianapolis. I was very impressed with his work with the DZAC. Then we started doing this back in Jeddah 2006. So it's now almost 9 or 10 years. And I must say that my cornea practice changed a lot after including DZAC in my procedures. In my very first cases, if I had a patient with cataract and that he needs DZAC, I would definitely do the DZAC first and then the cataract, or the opposite, depending on which pathology affects more the vision. But very soon, after the first 5 or 10 cases, I realized that the way to go is to do both combined technique together. And I'll tell you why in a few minutes. I have no financial interest in this. My indications for this, my first indication for DZAC is pseudophakic corneal edema. It's not Fuchs dystrophy on clear corneas like what I see in the Western world and North America. So our corneas, when the patient come to see us, they already have a corneal edema for a long time. The cornea are pretty thick and the edema is really bad. Second indication is Fuchs dystrophy, and when I do DZAC on a Fuchs dystrophy, this is my best day when I do DZAC on Fuchs dystrophy, because I can really see what I'm doing. But sometimes with severe corneal edema, it's very tough to do the DZAC cases. Rejected graft is my third indication, and CHED, the congenital hereditary endothelial dystrophy, is one of the important indications for DZAC in my practice. It comes number 4, but really it changed again the way we are giving service to these kids with CHED. Now the question is, do we do both together or staged procedures? So far, I'm not aware of any formal comparative study up to date. There is a study from Terry's group, a retrospective study on 2 separate group of patients, and the conclusion was there is no significant difference in vision or healing or rate of graft dislocation or mean endothelial cell loss. But the patients with combined procedure had a faster, speedy recovery. We know that doing cataract surgery after PKP for many years, there are many studies, and the safety is very well established. It's safe to do, it's relatively safe to do cataract surgery after PK if you take certain precautions. The safety of cataract surgery after DZAC is not yet well established. I wouldn't be surprised in the next few years that many publications and will have evidence that doing cataract surgery after DZAC is safe, but so far it is not yet there. So the advantage of a staged procedure is less potential complication, more stable IOL in the capsular bag, which is a big thing, that's an important thing. You don't want to see the IOL coming forward during the DZAC surgery. Lower vitreous pressure makes the insertion of the disc, of the DZAC disc, easier and safer. So these are the advantage of doing a planned staged procedure. But I would tell you that after a little bit of learning curve, a little bit of experience, don't do this on your first case, but if you've done 20 DZAC cases, and then you can start doing combined phaco and DZAC, and you will find no much no much increased risk or potential complications in your patients. I do the DZAC first only if I have a young patient who is less than 40 years old with a clear crystalline lens. Not very common, because usually Fuchs patient present at the age of 50 or more, but if it happens, then you do this DZAC surgery on a patient who is younger than 40 with a clear lens and the deep anterior chamber, then I would do DZAC first and wait. Maybe this patient will need a phaco surgery after 10 years or 12 years. Then you'll give him some time with reading and near vision before doing his cataract, taking his cataract out. If, of course, in a child with a CHED, then I will do DZAC because we want to preserve his crystalline lens. I would do phacoemulsification first only and plan a DZAC later only in very limited cases when the patient has a single-eyed patient, very high risk, if I think that the main reason for the visual deficit is the cataract, if I think that he might improve significantly if you do the cataract only, and then his corneal, his Fuchs is not that bad, there is no epithelial edema, the corneal thickness is less than 600 or 650, spectral microscopy are usually not conclusive in these cases, so I would rely more on the clinical signs. Without edema, without very thick cornea, I would give this patient a chance to do cataract alone. Maybe he will not need the DZEC. But in case when both are indicated, when DZEC is indicated and cataract is indicated, and both of them are contributing to the visual deficit, I have no doubt I'm going to go for a combined procedure. The likelihood of more complications is not that high. It doesn't really add much to the complexity of the procedure. Once you pass your learning curve, when you feel comfortable with the procedure, then you can easily do both together. And on the other side, there is a reduce in the risk of infection, of anesthesia. It's another procedure anyway, more convenient for patients if they are coming from far away, and visual recovery is much faster. There are a few tips I learned over the years doing combined DZEC and phaco. Make sure you have the best possible view, especially with thick corneas. And one thing I learned, other than scraping the endothelium, and I actually learned this from my friend Donald Tan in Singapore, he just open the eye with the speculum and then go and prepare his DZEC. While keeping this eye open for 5 or 7 minutes, then the cornea starts to dehydrate. And this improves the visualization of the anterior segment. Using dye is essential if you're doing combined phaco and DZEC. It might not be that important if you're not doing phaco, because when you do phaco, you need really to do a small rhexis, smaller than the diameter of the IOL, and it will make also your desmatorexis or your stripping of the desmat membrane easier. A small rhexis is important here. You want to have the lens in a good position. You don't want the lens to come forward anteriorly while you are inserting your disc. And anterior chamber maintainer is important. I use anterior chamber maintainer in all my DZEC cases, but some surgeons don't do this. But if you're doing a combined phaco with DZEC, then I think anterior chamber maintainer is very important here. In my DZEC cases, my combined procedure, I always use monospheric lens. I think this is the best for this procedure, monospheric aspheric. Remember that the disc induces some hyperopic shift and some negative spherical aberration. So there is no point in using multifocal lens, because the multifocals here they degrade the quality of vision, and also there is more aberrations from the disc. So the quality of vision is very compromised. So I wouldn't go with a multifocal lens in these cases. And aim at -1, because you know that the DZEC disc induces a hyperopic shift of between 0.5 and 1 diopter. So this clip shows you the preparation of the disc. This is the artificial chamber from Moria. I have no financial interest here. I use this in all my cases. It's very friendly to use. I remove the epithelium and then measure the corneal thickness, donor corneal thickness. And then I use the CB manual microkeratome so far. I know now they developed the linear microkeratome, which might be even more precise. I used this for many years for the LASIK back in the 90s, so I really like it. And then you do the first pass and then measure the remaining thickness of the cornea, rotate 180 degrees, so your angle of attack, the point where you enter the cornea, is 180 degrees apart. Otherwise, you might risk an irregular flap or a perforation. Then do the second pass, remove, then you measure the remaining part of the disc. Only one tip I'm going to give you, because I like this very much. I put the the mark on the stromal side of the donor, not on the recipient. And the reason I like this, because it gives you the better visualization when you inject the air. So when you inject the air, you know that this mark is on the donor. So you go with your cannula behind this injection, behind this mark, and you can inject safely. So this is around 100 micron disc thickness. I'm very happy with anything between 60 and 100. And then you go with the needle behind, and then you inject the air, and the rest is very easy. Here this OCT scan showing the single pass versus double pass DZAC. You can appreciate the difference in the thickness. It's like 150 in the first, or 70 in the first, and less than 90 in the double pass. So I think combined procedure is the way to go, unless you are in your learning curve. If you think that both pathology are affecting the vision, it's safer and faster to do both procedures together. A DZAC alone is preferred in a younger patient with a clear lens, of course. Cataract surgery alone only in high-risk patients when you think that you might improve and give this patient an acceptable vision without resorting to a corneal surgery. But planned stage surgery, I think, have no place except in your very first cases in your learning curve. And I thank you for your attention.
Thank you very much, Alaa. You can see we've had a full and interesting session. I think we are already quite a bit over time, and that means we have removed the chance of any discussion. Because if there is any pressing issue, I will still allow it. Thank you very much.